did gross like flexion and abduction, but those are you can put the arms in different positions so that we could definitely figure out which muscles are being affected. So
Okay.
we had to limit it in that regard.
Yeah, I mean, I would say, education kind of was
Sure.
Real fast.
quite a bit. And then, even at the end, how quickly we went through home exercises,
You wouldn't do that.
I take a long time with that one just
Yeah.
because I really need it to happen. So,
Yeah.
Yeah.
okay. So we have a few discussion questions. Okay. So what were some of the challenges that Megan faced, and kind of how would you guys approach those in your practice setting?
Kind of more from like a dominant parent and a passive child.
Mhm.
Dad wanted her to be like cured in like no time.
And I didn't really care too much for my sport.
I mean, does that happen in any other professions? I'm here, tomorrow I'll be better.
Yep. Yeah.
Or I'm sure like you've even seen like even as a teenager you would not give the whole truth, and then your parents back there like, well, you said this, 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 and this, and you're like, oh, okay.
So is there ever a time where you might ask the parent or any other family to do you mind stepping out? Any scenarios you guys want to outline?
Well, I mean, I think for us, going back to what happened with nutrition is you're in a completely different environment when you're doing speech. And when we have tests and they're standardized, it's completely different than talking to someone new. It's completely different than talking to someone that you know personally. So it can kind of be used as a roundabout way to take data. But so you kind of have to limit it. So, have them in for a second, get what you can from them, and then, explain, okay, this is going to take a little bit longer. Like he said, how long is this going to take? That's a really common, question that I get. And then you can just kind of let them know, well, hey, you don't have to be here. Nice way.
Yeah.
I think also, sorry, I was mentioning, but going off of what Sammy said also, we also get parents who will be like, oh no, you can say that, say it, and they'll kind of bombard their child. So we kind of the opposite effect too a little bit, making them look better than what they actually are, so that they feel a little better about their child.
And I know there's cases where as a physician you want the parent to be involved in the child's health care, definitely, and then you get both sides of the stories, but then it is important to ask the parent to step out because there may be things that the child wants to talk about but doesn't feel comfortable, mom doesn't know about it, they don't want mom to know about it, and it's important to take that into consideration as well.
Any suggestions on how we could have used segue better? Segue.
Same.
I do that every time. Anything you guys think that we could have done better, or that we missed, maybe?
I mean, it was quick, but obviously it could be 10 minutes, but otherwise I thought it was really good. Really, you guys explained, you explained it really good. Flowers.
How do you think, based on the limited scope of what you've seen, how our home plan compares to maybe home exercise or home treatment plans that you might give to your patients, if you do home treatment?
I think that it's just best to keep in mind, or important for us to keep in mind that our patients or clients might have homework to do at home from other professions, so that we might be asking them to do a food log, but they also might be having to do exercises in the morning and at night. So it's kind of a lot all at once, and it can be overwhelming.
Yeah, we definitely stress that a lot in this program, that you have to, if you give somebody 5, 6, 7 exercises and expect them to do them twice a day, they're not going to do them. So that's why you try to give them 1, 2, or 3 that you think are really important, because strengthening or increasing range of motion isn't going to happen 3 times a week that you come to therapy. Same with you guys, you're not going to get an accurate food log if you don't do it the amount of times that you're asking. So those are kind of the important things to think about as well.
In speech, we also make sure we give very specific homework like that as well. Just because if you say, oh, we want you to practice these words all the time, it's not realistic.
You guys have any questions for us about our eval, technique, structure, anything like that?
Do you guys diagnose like what's going on? Like if they have a rotator cuff injury?
Itch.
So,
Yeah, we say like signs and symptoms are consistent with.
Yeah.
But we do more of like, and we have the people, especially like an outpatient, where like they'll come in with a general like, oh, I have low back pain or I have shoulder pain, and then we do our diagnostic test and say it consistent with, or we'll get a script from the doctor saying this patient has a rotator cuff tear, and like we'll still do our eval the exact same.
so we are not allowed to like actually place a diagnostic code on. We can place like a functional ICD-10 code on that is linked to the diagnostic code, but all of our diagnostic codes are linked to the referrals that we receive from a physician.
Okay.
Would you ever refer the patient, they come to you first and you're like, something's really wrong here, then would you refer to a doctor? Is that how it works?
Yeah, we're actually in a class right now. Since it's our last semester actually here, we're in a class that people bring in cases, and it's your job to decide if you have to treat and refer them or just refer them back. So that's kind of interesting that if you feel that it's not within our scope, like you can refer them back to their like doctor, and they can say they might need maybe a neuro consult or cardio, like something that you think based on the test that you did, so that they can get the patient where they need.
So does that happen more like for outpatient, like a patient that came in like you were talking about with like low back pain or shoulder pain that you send back to the doctor, or is that patients that a physician has referred to you that you send back to another
Both.
physician? Both.
And it can be in any setting. Like we had an example, it could be in acute care where like the primary physician was a cardiologist, but then they had neuro symptoms. So like we were like, yeah, like we think it would be, this patient would benefit from a neurology consult, and then go from
So in the case of this 16-year-old girl, let's say, and kids involved in sports too, so maybe would it be a coach, or if there is an athletic trainer or somebody, they might say, I think you should see a PT, or like how does this come in? And then they might come directly to you, or do most kids in sports go to their doctor first? Like how does that happen, and then how do they end up seeing you?
I think it really just varies, and it kind of depends, like, if your school, like if they're in high school and their school provides an athletic trainer, they might go see them first, or then maybe go to their doctor or PT, but sometimes, once we get it all kind of figured out and we get the exercises, like, what they need, especially for kid in athletics, you could give it to the athletic trainer, because maybe athletic training is covered like through their school, and PT their parents might have to pay for. So it might be easier to send them back so that they can keep their PT visits, because now insurance is getting really limited with how many visits somebody can have, so in that regard.
So in this case, you wouldn't have needed to send her back to her doctor at all?
No.
Yeah.
there. We usually write a note to the doctor though.
Okay.
Letting them know
I saw-
like, this is what we found,
Okay.
this is what we're treating.
I have a question. So coming from OUH-COM, which is a DO school, which does osteopathic manipulative medicine, I don't know if you guys know anything about that. What is kind of your partnership with the OMT? And do you often work in partnership with DOs who do the manipulation also, in kind of like the partnership with physical therapy?
In my clinic, and it's limited at this time, but I have not worked directly with a DO that does OMT. We do manual therapy and bill for manual therapy in clinic if it's related to the diagnostic code that we're treating, and if that patient presents with those deficits. I'm not saying that I wouldn't, I just don't think I've come across a setting where that has occurred. I get a lot of referrals from DOs, but this time I haven't. I don't know if you guys have.
Yeah, and I guess like kind of the same thing that we've talked about too, that like Chiro is obviously kind of the same thing. They perform different manipulations as well, but if they're also seeking out you guys as well, we're not going to try to do the same thing. So we might focus more on the exercises, range of motion, if we know that they're still seeing you for like the osteopathic part of it. So I think it kind of just depends who's on their case and where that comes from.
Thank you.
Thanks, guys.